Hello, Professor Susan Davis. We are live. Thank you so much for joining us on Menopause Masterminds. I can't even talk this morning. Masterminds, it is too early for me. For the Menopause Research and Education Fund. Let me quickly introduce you because it is quite a long CV and a very, very impressive one. So I've tried to truncate it a little bit. You are the author of more than 435 peer-reviewed research papers and arguably one of the world's leading investigators in women's health, including menopause and testosterone. Your research has been pivotal in the understanding of sex hormones in areas outside of reproduction, which is very, very interesting, in the brain, on cognition and mood and sexual function, heart, cardiovascular system, bones and muscles, even fat, these kinds of things, areas that we are nice outside of just reproductive health. You're also the past president of the International and Australasian Menopause Societies. You've probably sat on more chairs and boards than you can care to count or remember. And you've been appointed as an officer of the Order of Australia for your contribution to science and education. You also, in your spare time, head up the Monash University's Women's Health and Research Program while also working as a consultant endocrinologist. And you're also an advisor on the NHS Menopause Improvement Program Steering Committee. That's quite a lot of stuff.
Yeah, it keeps me busy.
Yes, it does. Now, what was it that drew you towards testosterone in the first place, looking at it for women?
Well, when I was a young trainee, I was working in the clinics where we were giving testosterone pellets to women who had low libido, and I didn't believe that this was particularly effective or safe. So I did a study looking at it, and to my surprise, we showed both efficacy and safety. But it was a very small study. I really have to emphasize this was a study that involved 38 women, and they were involved for over 2 years. But having said that, we did show that there was a benefit, but it was not sufficient to show safety across the board. But it really then tweaked my interest in what's happening here. Why does testosterone matter for women? So that was where I started with it.
Since testosterone has become quite especially here, a very big talking point. It's now regarded as, the sort of the third leg of the HRT story, and there's a lot of claims being made about it. But before we get to the claims, I think it's probably important for people, especially if they don't have a science background, to understand how it is that we build a body of evidence. Because people will say, well, hang on a second, there's a study over here that says this, and then there's a study over there that says that. But at what point do we go, right, we've got enough stuff that says we need to change practice? How do we build that body of evidence?
So firstly, you observe something clinically. So you observe that testosterone's in women. We know that you do blood tests, there are testosterone levels in women. What does it do? Oh, we think testosterone's related to sexual function. Why don't we ask women and look at blood tests? So we do what is called observational research, where we do a whole lot of questionnaires for women. What's your sexual function like? And then we measure blood levels and see if there's any association. And in fact, so far, there's virtually no association between blood levels in testosterone and sexual function in women in the studies that we've done. But then we say, well, we still think something's going on here. Why don't we do a study where we randomly allocate women to testosterone or an identical placebo? So I don't know what the patient's taking. The patient doesn't know what they're taking. And we see if there's a difference in women who get placebo versus women who get the actual testosterone. And there is a small but statistically significant difference in improvement in sexual function in women who get testosterone. But you have to do a placebo-controlled trial, because placebo effects in many of these outcomes, like libido, like mood, even in menopause, like hot flushes and night sweats, there's a huge placebo effect. About 50% of women improve with just placebo. You don't need estrogen. So if you don't have a placebo-controlled study, you can't be very sure that your treatment's all that effective.
Good point. When people then hold up one study and say, well, look, hang on a second, this one says X, how much weight can we put on a single study on its own?
So studies have to have several attributes. you want the study to be double blind, so the people running the study and the people in the study don't actually know what they're getting. The study also has to have sufficient number of people in the study for you to believe the results. So, for example, we did a study years ago looking at whether estrogen would improve angina, chest pain, in men. So we did the first 10 men, and we unblinded to the study to see if it was worth going on. And it looked as though that the first 10 men, there might be a benefit. Then we did the second 10 men and showed no benefit. So when we studied 20 people, there was no benefit. But in the first 10, we had some sort of responders that biased our results. So if you do a study of 30 people and testosterone, it might be by chance that you've just got better responders to the whole concept in one group. But if you do a study of 500 people, then you're going to get rid of all those biases. So it has to be big, has to be double blind. You have to use proper measures. So you don't want to just ask women how they feel. You've got to actually do validated questionnaires. And then the best studies are studies that when somebody repeats your study, they get the same answer.
So being able to replicate something is very, very important.
Yes.
If somebody holds up a study and says, well, hang on a second, this one's working really well for this. Because I think people often miss that last sentence in the bottom of a conclusion, which often says more studies needed. And so, something might point in a certain direction. And people go, well, this must prove then that, testosterone is going to cure dementia and brain fog and all of those sorts of things. Is there a danger in taking one study in isolation?
It's extremely dangerous, and that's why we did what's called a systematic review and meta-analysis. So we collected the original data from every study that had ever been published on testosterone in women that was at least blinded and at least of 3 months duration. And we combined all the studies together to look at the outcomes. I mean, we looked at all the studies that looked at sexual function together, and the ones that looked at brain function together, and ones looked bone together. And when you put all the data together, say for studies of testosterone and bone, how do they all tally up when you make them one big conglomerate? Do they all agree or do they disagree? Is there evidence here to say testosterone improves bone density, for example? And you need to be able to see how they all line up together. And studies where there have been 15 women in each arm of the study are going to be considered a lot less powerful than, say, a study with 100 people in each arm, because you've got more of a chance finding if it's a small study.
Yeah. With testosterone, you mentioned before that it can be quite useful for some people with low libido, but you also mentioned that there's no association with the blood levels in particular. But we seem to be at the moment. We often think, I went to my doctor, I got my levels back, and I was low, or I was within normal ranges, but I still feel quite bad. What is it about testosterone levels? Are they particularly difficult to assess in a outside of a giant university laboratory with expensive equipment? How reliable are they as an indicator of the way you should feel?
Completely unreliable, complete rubbish.
Okay. Why is that?
Because testosterone levels you go to a regular laboratory, testosterone is measured in the same system that's used to measure testosterone in men. So the range of blood levels in men, say 10 to 30 nanomoles per litre. The range in women has never been defined for midlife women. Let's get that clear. Secondly, if we think that maybe the levels around about between 0 to 2, I can be confident using this measurement that if a man's blood level is 15, it's actually different to 20. I'm not very sure that 15.1 or 15.2 is different to 15.8.
Mm-hmm.
But where you're trying to use the same assay, the same way of measuring testosterone, and expect it to tell me that 0.6 is different to 0.4 or 1.8 is different to 2, it's not that accurate. It's too blunt an instrument to measure differences in the small levels we see in women. So I could take your blood, divide it into 6 samples and run it several times, each sample a different day, and I'll get a different result. It's too gross, blunt an instrument. So measurement is not accurate. The second thing is that there is no normal range for women. There's no reference range for midlife women because no one's ever done the study of large enough sample of women to give us a reference range. There's no evidence that low means anything. There are plenty of women walking around with great sexual function and their testosterone's at their boots. It doesn't, in their blood, doesn't mean anything. The only use for a testosterone measurement is if a patient comes to see me and she's suddenly got acne or excess facial hair or body hair. She's become masculinized. So then it's quite good at the high end of the female range at telling me that I can find a level of 4 or 5, and I know this woman's abnormal and I have to start looking for a tumor.
Yeah.
But it's useless for what's available in routine clinical care, and people should not be having their blood levels measured to see how they feel.
I guess that the only reason then it would be useful is if you've started on testosterone and you want to make sure that your levels are still within what would be your normal physiological ranges.
No, we don't have a normal physiological range.
What they would call between your 0 and 2, so you're not coming in at 4.
I measure it if I want to evaluate a person who comes in with masculinization, or to monitor a patient on treatment to make sure she's not just bathing herself in the stuff. Yeah. But there's no clear upper limit, which is definitely abnormal, or a lower limit that's abnormal. And that's what we're currently trying to establish. That's the research we're doing. So if someone's told their testosterone's low, it's meaningless.
Fair enough. The when you start treatment for low libido, how effective is it? How many women actually find that they get a benefit?
About 60% after they've been properly screened. So in all the clinical trials, if you line them up, women presenting with low libido who have been screened out, we've screened out women with depression on a whole host of medications, you get about a 60% response rate. And the response is often more modest than women expect.
Yeah, that's a very true thing, isn't it? Because some people sort of call it a slow burn. Some people find that they don't seem to sort of get any kind of response. Is that leads to the other question is like, well, am I not having enough testosterone? Is that the only reason, or are there other impacts, other things that impact upon libido that should be taken into consideration and making it a multifaceted treatment?
Well, treatment of low libido should always be multifaceted because libido is not simply determined by hormones. Libido is determined by relationships, by whether you're getting enough sleep, whether you've got menopausal symptoms, whether you're stressed at work, whether you've got worries, how long you've been in a relationship, what the relationship's like, what your expectations are, what your partner's expectations are. So it's not simply, here, take this medication, it's going to fix the problem, because that's not what it's about. And really, when you think about it, it shouldn't be that simple.
No, I guess not, which is rather sad because we seem to like quick answers and things these days, which leads me then to my next question is there are an awful lot of claims being made about testosterone that, it's going to clear brain fog, that it gives you more energy, that it's builds your muscles, that it is generally sort of being touted as something that all of us who are on HRT should probably have as the third leg of a stool. Is there any evidence to back that up?
No.
Fair enough then. Now, some doctors would probably say to you, look, Susan, I've got women coming through the door of my clinic every day. They've started on testosterone. Not only are they swinging from the chandeliers, having the best sex they've ever had, they're also doing it blindfolded, simultaneously doing Sudoku puzzles and talking about how they've just got a pay rise at work because they've met all of their quarterly targets within the first 3 weeks. So they're saying that they're seeing a very, very different picture. Why do we seem to have this disconnect between what doctors are seeing in clinical practice and what happens in the trials?
Well, I've been in this game and been prescribing testosterone for women since the mid-80s. So I think there's a lot of hype and hyperbole and embellishment. The placebo effect is enormous. So when we did the very large studies, and I'm talking about the largest study I've done was 800 women recruited to a study for 12 months across 3 continents with 84 clinical trial sites. We found statistically significant improvement in libido. There was no improvement over placebo in general well-being or in mood. There was no change in any other outcome. And the biggest problem in the analysis of that study was the placebo effect. So we had women on placebo when we unblinded the study who had massive improvements in sexual function, and they were on placebo. And it was like, how do you, it was mind-blowing improvements in sexual function. But when we actually worked out what they were taking, they had placebo. So not everybody. So if I'm going to a doctor who's very charismatic, who quotes me a whole lot of information, and I pay a whole lot of money, the probability I'm going to get better is huge. And that eventually wanes over time. But there are a lot of beliefs that we have shown in trials to be placebo. We did a randomized control trial of 100 women, so 50 women in each arm, looking at effects on cognitive function using a computerized battery. There was a borderline statistical improvement in one aspect of memory, verbal memory, and nothing else. And it was, if I remember, it was immediate recall improved by 1.57 words. There was no dramatic improvement in any other aspect. And this was a very complex computerized assessment where if there's any subtle improvement, we would have picked it up. And so there's 50 women in each group, and mostly in most of the outcomes of cognitive performance, there was no difference.
Interesting, because some might argue, well, hang on a second, maybe your tests aren't fit for purpose. I mean, how do you measure the fact that, I was standing in a giving a speech or in court or whatever, giving my sum up, and all of a sudden the words went out of my head and I couldn't bring them back. Are the tests, if you're asking me sort of verbal recall or the sort of much more amorphous in and out of a thought, are the tests fit for purpose, I guess would be
this particular computerized battery is a very modern system, and it is fit for purpose, and it's used universally to pick up really subtle changes in healthy people. So the old-fashioned tests were designed for people with brain impairment, and so we're using tests that even people with mild impairment and cognition would still perform normally on. The kind of battery of tests is multidimensional and looks at a whole range of different cognitive tasks. And it is the one that's used, for example, in athletes like rugby players or jockeys or people who compete in sports, where if you have a concussion, you have to return back to your own baseline. It's your own baseline. It's not someone else's. So I'm not being compared with you. I'm being compared with my baseline. And then you do the testing. But it picks up really nuanced effects. And we did not see nuanced effects except a very slight effect on verbal memory.
Okay, interesting. The other claim with testosterone that seems to be emerging now is that, it's neuroprotective, so therefore we should be having it to prevent dementia. Is there anything that backs up that?
There's a series of Petri dish studies. So in brain cells in dishes suggesting that there might be neuroprotective effects, but there's nothing. It's really, really, really old data. So people are dredging up old data. No, we don't have, I would not tell you if you came to me as a patient that this is going to make your memory better and going to protect you against cognitive decline. And our published research has shown no difference in cognitive function in older women in relation to blood testosterone levels. And we showed no difference in brain aging using MRI scans in relation to testosterone levels.
So there's nothing there at the moment then that is showing that it could actually make a difference. Because I mean, some people would argue, well, hang on a second, okay, our estrogen's gone down, our testosterone's gone down, and then sort of plateaued. Men get less dementia than we do. So has it got to do with the fact that we've got less estrogen and less testosterone, and they've got more, so therefore we should have more?
No, and we have shown that after the age of 70, testosterone levels increase in women. That's probably why women get facial hair once they get elderly. And that this is unrelated to cognitive function in older women. So we have shown at this point, based on what is available, we've not been able to demonstrate meaningful cognitive benefits of testosterone. We've reviewed the entire literature systematically. There's no consistent evidence of benefit.
Is there any evidence of the opposite of benefit, of actually doing some harm?
No, at this stage, there does not appear to be, except if you take too much, you will masculinize. There's no question. If you take it orally, which we discourage, that it will affect blood cholesterol levels. I suspect if you probably take too much non-orally and you get your levels high enough, it potentially could have adverse effects. But if you get masculinized, it's starting to get towards too much. So it's the potential harm, though, is one, women spending a lot of money on something that they actually may not be benefiting from, and two, treating things like low mood and depressive symptoms with testosterone when really it's not going to fix those symptoms, and women should be having appropriate therapy.
Yeah.
And those conditions should be properly diagnosed and managed. So there's too much of this, as I said, there's too much embellishment and hyperbole about the benefits that have never been established. And I think we should start being honest with women and say, this is the data. I mean, I don't make money out of telling people not to take it. In fact, people think I want to prescribe everybody testosterone, but it's not the way to go. And right now, this is the research we're doing. We're trying to get the research to advise women. My belief is, if I think that women might benefit from testosterone from all these things, I should study it in a clinical trial that's properly designed and not do a human experiment at women's expense.
Fair enough. Speaking of human experiments at women's expense, you mentioned that some people may find that they don't get much of a benefit, and there are sometimes when people do, they stop for various periods of time. If they find that they don't notice any difference, then does that mean that basically it wasn't making any difference and they should stay off it, really, because they're not getting that benefit?
And I think that's our approach. My approach is women come to see me with low libido. They want to ask about testosterone. We discuss everything. We talk about all the options. We make sure we treat the vaginal dryness. We discuss the relationship and so on and so forth. We do all of that. Then the woman can have a trial of testosterone. It's approved by our drug regulators. It's available to go to a pharmacy. It's not a big deal. There's no hype. It's not seen as the special hormone. It's seen as something that may help them. They try it. And I would say probably I don't even know now, maybe 50% of women will continue on it past 6 months. A lot of women will say, hasn't really helped, and they stop. But it's much easier for them to say that and to experience that if you haven't hyped it up as a therapy.
Yeah. Yeah. The other area where it's getting a bit of attention to is preventing heart disease. And I think there was a study that showed that there was an association between low testosterone levels and poor heart health outcomes. Is the logic then that by simply replacing the testosterone, you'll decrease the risk of heart attacks, or is the logic flawed?
The logic's flawed.
Firstly,
we looked at about 5,000 women age 70 and older. They're age 70 to 94. So it's got nothing to do with a 50-year-old, age 70 to 94. And we looked at their blood testosterone levels, and they were followed to see if they had a cardiac event over the next 5 years. And women with the lowest testosterone levels were more likely to have a cardiac event, a heart attack, an ischemic stroke, whatever. But that doesn't mean low testosterone is the cause of that outcome, and giving testosterone is going to prevent anything. It may be a biological marker of better health or worse health, because once you're postmenopausal, your testosterone comes from hormones made from the adrenal glands. Everyone talks about DHEA. The adrenals release DHEA, it's converted into testosterone. This might be just a marker of adrenal function. It might be a marker of the cell machinery to make testosterone, but have nothing to do with your actual blood testosterone level. We don't know. So we are now looking at testosterone in people with heart disease to see if there is a benefit. There might be no benefit. But to go around telling 50-year-old women, if you take testosterone, it will prevent heart disease, is completely inappropriate. And it's basically manipulating the data to support your beliefs.
It's I think cherry picking would be the word.
Cherry picking. I could sit here and tell you, spout out a whole lot of data that would make everybody believe testosterone is the best thing since sliced bread. There are studies that would suggest it's bad for women. It increases heart disease risk. There were studies to suggest women with higher testosterone have higher blood pressure, not lower blood pressure. You can't cherry pick the literature. Well, you can if you want, to give the story that you want it to believe. Honest evidence-based medicine is saying, let's look at all the published studies, and when I put the whole story together, what do I see? Not, I believe that testosterone prevents heart disease, so I'm going to find those studies that back up my theory and ignore everything else. You can't do that. It's wrong.
What do you think we need to get to that point then where, which is one of the main reasons why I've set up the Menopause Research and Education Fund, is hopefully to get enough money to actually help people do the kind of, help you do research, help other people do research, to get to that point where we have some sort of form of consensus. How much more do we need, and what sort of studies would you be wanting people to focus on? Because you mentioned then that these people are over 70, yet we're talking about people, we're talking about perimenopausal people, people much younger, perhaps being told that they should have these sorts of things. Where do you see the priority for research in that area?
So what we've done, Fiona, is that we have set up a study. We haven't got funding for it, but I just went ahead and did it because there are all these issues. We have recruited 8,000 women aged 40 to 69 across all geographic regions of Australia, even rural and remote. We recruited women to a study of midlife women's health. So we didn't tell them what we were looking for. That's the first thing. You don't do a study of polycystic ovary syndrome and tell women we're studying polycystic ovary syndrome, because who's going to go in your study? Women with polycystic ovary syndrome. So we just said this is a study of midlife women's health. And we have collected vast quantities of information from these women. They've completed validated questionnaires, and a good proportion gave us blood samples. But for example, we have then about 70%, we were able to stage their menopause status by their bleeding patterns, because they're not on HRT, they're not on anything. So we're able to tell whether 6,000 women are pre, peri, and post by their bleeding patterns, right? So then they've all done extensive questionnaires on symptoms. So what we're about to look at is, let's take fatigue. What proportion? People will say fatigue is a symptom of the perimenopause. Well, is it? Women have told us, do they have fatigue, yes or no? And if they say yes, they score it from 1 to 7. So we can see what proportion of women have fatigue who are pre-perimenopausal or postmenopausal, and how it varies across those stages. So we're going to say Well, 60% of premenopausal women have fatigue. We haven't got the data yet. I'm just saying as an example.
Yep.
And 65% of peri. How confident we are that that really is a symptom of menopause? Whereas we might see, for example, I'm really giving examples. We haven't analyzed the data. We might see that migraine changes dramatically at perimenopause. And then we're going to say, oh, there's a doubling of the prevalence of migraine at menopause. Gee, that really might be a hallmark symptom. But right now, we really don't have that data. So apart from hot flushes and night sweats, many of the other symptoms that people are using to define perimenopause may not be very reliable. And we're trying to break it down. So firstly, what are the symptoms of menopause? Because otherwise you don't know what. So people are self-diagnosing. We really don't know what's going on.
Yeah, because that list is now, I think, depending on whose list you're looking to, you're up to 60 or 70 symptoms. It seems to be moving exponentially.
Yeah. So we're sort of trying to break down wherein lies the truth. And then we're looking at the association between menopause and a whole host of outcomes: sexual function, mood, sleep, work, relationship, just a vast amount. So how do all these factors influence a whole lot of outcomes? And then we're looking at hormone levels and a huge number of outcomes, hormone levels measured with precision. And that, I think that's the basis. And then what you find from that tells you where you need to do clinical trials. And you have to do the observational research, but it has to be unselected samples of women, large enough groups of women, women in different circumstances. And without that, you can't, a lot of hot air is being expended.
True, but I suppose most of us would look at that and would think, well, hang on a second. We've all gone through menopause for millennia. Why the hell don't we know what the symptoms are already? Why is there such a paucity of research on something that affects so many people?
Well, when we did a cross-sectional study of 2,000 women, nationally representative sample, and we published a lot of work from that. After we did it, we collected the sample that we recruited the women to in 2014. We struggled to get funding. We put into, all the big organizations. We told, we don't need to know this. Why do you need to know this? No one would take HRT because it causes breast cancer. So since the Women's Health Initiative study, menopause has been off the radar. No one wants to talk about it. And I think because of this big gap that was left there since the Women's Health Initiative study, a lot of that gap has been filled by a lot of misinformation or uncertainty. And now we need to revisit the whole menopause timeframe and look at it again. And the other thing to take into consideration is that life's changed. 80% of women in Australia are working when they go through menopause. It was like 45% 40 years ago. Women are delaying childbirth. You're more likely to have a 10-year-old that you've got to manage when you're going through menopause than 30, 40 years ago. There's more elderly care. Our parents are living longer. So you've got the 10-year-old, your job, and your 80-year-old mother who isn't coping, and your father's died or whatever, or your 80-year-old father and your mother's not there. I mean, it's become much more complicated. So, and the other thing is with menopause is that women are in more diverse employment than they were years ago, and more senior roles, or more women are in senior roles. So trying to work out what is impacting them, causing them great stress, anxiety or low mood or sleeplessness. Is it the menopause or is this other stuff happening? We don't know.
I guess though, some people say, well, hang on a second, I've been dealing with my teenagers for years. I've been dealing with my parents for years. I've been at my job for years, and I've managed them all. But now all of a sudden I can't. Something's changed. So, and then they will.
believe me, I'm not saying that menopause doesn't make a huge difference, okay? But it doesn't make a huge difference for everyone. There are many women, I see women with osteoporosis, and I say, well, and they'll be, say, 65, 70, 75 years old. I see them with osteoporosis, and I ask them about their menopause, and they go, I don't remember. It wasn't particularly important to me. Nothing much happened. So I think that we assume that everybody has this horrible experience at menopause. Not everyone does. Most women doesn't really bother them. Our qualitative research suggests that as well.
Yeah, it's an interesting one because, when we now have, obviously it's very politicized. We have one side basically saying, oh, get over yourselves. Everybody's gone through this for millennia. What's wrong with you? It wasn't a problem. Go and jump in a bath of cold water or a bucket of ice and you'll be fine. And then we've got the other side saying, well, hang on a second. We've got to have, incredible workplace changes. We have to have much more understanding of this. We have to have a much more nuanced approach. Where do we find that fine line between not sort of making people think, oh my God, I'm never going to employ another woman again, and also but making sure that those that that 30% who do have quite severe symptoms and the other up to 70% who have sort of moderate symptoms, that they are getting the help that they need? How do we find that fine line?
Well, I think that our research has shown that there's very poor understanding of menopause in the community and a lot of misinformation. So getting valid community information out about understanding what the hormone changes are, how hormones are important for your body, and if you have changes, but not preempting them, if you have changes, how to get help. So we're working on, we've got a co-designed menopause screening tool. So if a woman's going to the doctor, she can complete this checklist on the app on her phone. And when she gets to the doctor, it's already flagged. It's not telling her these are the symptoms she must have. It's saying, do any of these things bother you? But it's not the list of symptoms that tell you this is menopause. So I think removing that. So if the woman turns up and says she's got low mood and sleeplessness, it's not, oh, must be menopause. It must be, we need to talk about all the causes of low mood and sleeplessness. Similarly, we need to upskill our doctors. And we know that. We know that there was so much misinformation for over a decade. We have a whole generation of doctors not trained in menopause care, and another generation who were so terrified to prescribe HRT in case that they got sued that they completely lost their skills. So we need this two-sided approach, and then it's about a sensible conversation, but not catastrophizing anything. And then having available treatment options, but not running around telling women everybody needs hormones and everybody needs testosterone when they don't, because that's just wrong. And if the symptoms aren't going away, just up and up and up the dose till you're on a dose that I see women come to me with doses causing blood levels like you'd see in pregnancy. I've had patients in Australia who have consulted with UK doctors, and they're on so much estrogen, their blood levels are like pregnant women. I don't know what that does to breast cancer risk. And we do know an explosion of breast cancer with inappropriate prescribing.
The counter argument that you may find for that is then that people will come along and say, well, hang on a second, we've got huge amounts of data on high levels of estrogen in the transgender community, so therefore we must know that it's safe. What can we take away from that argument?
The transgender community is biologically different, and we do not have, you need to give somebody who's biologically male, an XY, who transgenders to female, you need to give a lot more estrogen to feminize them. And they have different metabolism of estrogen. They're usually bigger body composition, different size livers, different liver functions. There are biological differences. They haven't had, we haven't had the experience of generations of transgender people who have transgendered to female from childhood, from early adolescence, mid-adolescence, who've had exposure to estrogen for decades. So we don't know. And we don't have the evidence of breast cancer safety in that population. And I think it's inappropriate to say, well, there we go, we know. We don't know.
It's interesting because it's very powerfully put sometimes, and very, I mean, in sort of like, well, hang on a second, we know because we've got this community and they've been taking it for ages. They're not dropping dead from heart attacks. They're not dropping dead from breast cancer. So surely the evidence is there. What more do you need to do? But you're saying that basically you really can't compare an apple with an orange.
No, you can't. And then people are running around and saying, oh, if you use progesterone, it's perfectly safe. There's no association between progesterone and breast cancer. I would never say that to a patient until we get the data. We do not have that data.
No, a thought crossed my mind, which if we have time later, I will come back to. Let me go to the one of the other claims that's often made about testosterone is that it's going to improve your bone muscle density and decrease your risk of fragility fractures and osteoporosis, and increase your muscle strength if you take it as a woman during menopause. Do we have evidence to support those claims?
No.
You're becoming Dr. No today, because logically you would think that it would.
Our randomized clinical trial of about 15 women in each arm showed a statistically significant increase in bone density over 2 years. Okay, 15 women in each arm in a study conducted in the 1990s using testosterone pellets, which gave very high levels of testosterone. We don't have data that physiological doses of testosterone improve bone density in women, and we're doing that study now. That's why we're doing the study. The reason it's being funded is because we don't have the data. And when we've done the systematic review of the literature and analyzed all of it, all the data is put together, though it's one study, it comes out as a null outcome. And there is absolutely no clinical trial fracture data for testosterone to show that will prevent fractures. Not a single randomized clinical trial showing testosterone. No one's even looked at it. So you can't say that there's an outcome. That testosterone prevents fractures in women. And in terms of muscle function, we've looked at blood levels of testosterone and muscle strength, and there's no association. And the clinical trial data is too uncertain to suggest that there may be any benefit. So we've looked at all of that. And we are currently doing a randomized placebo-controlled trial postmenopausal women to see if testosterone will improve muscle strength and function using very sophisticated computerized techniques to measure this. But without that data, you can't say it. It's just talking hot air. It's pretending that there's data when there's none in existence.
No, but I suppose anecdotally, again, people will say, well, I started taking it, I had more energy, I got into the gym, my muscles are now 3 times the size. But, you know, if they'd got into the gym, their muscles probably would have been 3 times the size anyway. So you really
need a placebo-controlled trial.
Yes, exactly. When it comes to testosterone, is it kind of hard to study, not just because of the measurement difficulties, but also because some of it, this may be a very stupid question, but because some of it converts to estrogen. So how do you know how much is a testosterone effect?
Oh, we were interested in that from the libido perspective. So we did a study where we randomized, everybody was on estrogen. Everybody got testosterone, and half the women got a medication that blocked conversion of testosterone to estrogen. And that showed that the impact on testosterone was independent of being converted to estrogen in women on estrogen therapy. And that's the study where it suggested there might be a cognitive function benefit that was not better than the women on estrogen therapy, but there might be a benefit. But we didn't have a proper placebo control, and it was using very gross measures. So again, people cherry pick that data to try and make claims about things. You know, I would love to be able to say testosterone is the elixir of youth for women, but we haven't got the evidence for that. And we don't even understand it properly. We don't even know if testosterone changes at menopause.
Well, that is the point. I mean, if it does that sort of continuous decline, it doesn't seem to really have much of a because it starts before that decline, doesn't it? So it's
Decline, we've shown that testosterone levels fall about 25% in the reproductive years from about the age of 20. Our old data using imprecise measures shows that there might be a decline in testosterone slowly with increasing age, unaffected by menopause, unless you have your ovaries removed. But that was using very gross measures, not a big sample, but now we're going to look at it in 1,400 women using mass spectrometry measures, very precise measures. So we're looking at that now.
fair enough. The with some of it converting to estrogen, possibly if you're not well estrogenated, and having testosterone receptors all over the body and those kinds of things as well. What do we know about the safety of testosterone and cancers, hormone receptive cancers?
Look, it's our big trials have not shown a significant increase in that. It seems to be, when we've actually done biopsies of the uterus, it seems to, if anything, in women not on estrogen, have no effect. Women with breast cancer often have testosterone receptors. So I am very reluctant to prescribe testosterone to a woman who has had breast cancer, and also it can be converted to estrogen. And if they're on what's called an aromatase inhibitor that blocks testosterone converting to estrogen, they usually have high testosterone anyway. So it makes no sense giving them more. So in terms of causing cancer, there doesn't seem to be a causative role for physiological levels. In terms of treating women with breast cancer, we generally steer away from it.
Okie dokie. For people who've gone through surgical menopause, POI, early menopause, is there, they're told to go on HRT until around about the age of a natural menopause. Should they also be considering testosterone in that? Is there any evidence for testosterone in people who've gone through menopause early?
Well, that's what we're trying to look at now.
Yeah.
That's an unanswered question. The one study that looked at that found no benefit, but they used a lowish dose. That legitimately argued these women, if they've got normal adrenal function and still pumping out a lot of adrenal hormones, they shouldn't need a lot of top up compared to, say, a 50-year-old woman who pump out less adrenal hormones. And that showed no benefit. So I certainly do not push it for women with early or premature ovarian insufficiency, because there's no evidence that there will particularly be a benefit. And often those women have very good adrenal function and plenty of DHEA and plenty of testosterone.
Fair enough. There was a question earlier about testosterone. Is there a possibility, or can it be associated with increased levels of anxiety?
So in the past, when we didn't have the choices we have today, before putting a testosterone implant in the patient, to make sure there was no adverse effect, we'd often give them a tiny testosterone injection. And if you gave too much, women just felt so agitated and so irritable and so angry that there's no question. It's a bit like many things. It's a bit of a Goldilocks effect, that if too much is bad and too little is bad, and there is a just right. And I have seen people treated with a lot of testosterone who have really been very agitated and angry.
Yeah, interesting that, especially because we have so many, I don't know whether or not, there are an awful lot of supplements on the market over here that seem to be suggesting if you take this, it's going to boost your estrogen levels, it's going to boost your DHEA, it's going to boost your testosterone levels, it's going to do those kinds of things. Is there any evidence that any of them may actually do anything or could have adverse effects?
I mean, the problem with buying anything, supplements or anything over the internet, or just supplements, there's no guarantee that putting all together this combination of stuff is good for you, and how your liver's going to handle it, or what's even in it. And particularly when you get, a patient of mine was on some sort of tonic from a herbalist, and she had no idea what's in it. And I'm like, if I prescribe something for you, you'd ask me what's in it, what the side effects are. You don't even know where this stuff comes from. That baffles me, that people are such undiscerning consumers of things that they put in their body that could affect their health.
Yes, it's natural, so therefore it must be good for you, and it came out of
And
a gut.
true natural therapies can be very dangerous.
Yes, I did a walk around the physics garden again yesterday, looking at the poisonous plants that make that point. Yes, interesting. You've done you and your colleagues have put together, because if people don't know, in Australia there's a Senate inquiry going on at the moment into menopause. You've done a submission to it, and actually a lot of you raised concerns about the marketing of menopause in that. What are you particularly worried about?
I'm worried about that there's unregulated recommendations of alternative therapies with no evidence base that poor women are spending a lot of money on. That there's a lot of pushing of compounded hormone therapy, that it's more natural or safer. Where there's estrogen, there's estrogen. There's no estrogen plant. Doesn't matter where you get it from. It's made in a factory. It's not more natural. It's not necessarily safer. That there are people making claims that they run businesses that can come and designate a workplace as menopause friendly. We don't know what a menopause friendly workplace is. We don't even know what problems there are in workplaces. So this evidence base that people making money out of menopause like this is, I think, just reprehensible. I think that people are almost creating a situation where employers are not going to want to employ midlife women, and will result in less opportunities for midlife women in the work. I mean, if my daughter was pregnant and she was shortlisted finally for a job, and it was between her and somebody who wasn't pregnant, I mean, who are you going to employ? Seriously. You're going to employ a person who's not going to have their baby in 5 months, right? She was honest about it. She could have lied. If we keep going the way we're going and someone's 49 and got 2 kids and going for the same job as an equally qualified 49-year-old bloke, who are you going to employ if you think you're going to have to give them menopause leave and maybe they're not going to be able to function at work because you've read all this stuff? So I think that we need more information, we need more education, we need more awareness, but we don't want to catastrophize menopause.
No, true, because we do have evidence that, women on boards, and even though we're massively underrepresented still, improve the quality of a company. Women in high levels improve the quality of a company. So, I mean, obviously women who go through menopause are actually capable of doing work. So yes, we need to have that some sort of balance there where we're not being sort of, because we do contribute. We do have brains. Well,
and it's about common sense. I mean, it's not just about menopause, it's about reproductive health. I mean, we do need to make sure that in employed situations when, don't get me the wrong way, I don't think that everything's right at the moment. Things need to be improved. But in employment situations, we need to make sure there's adequate facilities for women in terms of bathroom facilities and privacy, so that if you suddenly had a massive menstrual bleed, you're not in a toilet thing that you've got to get out and sort of somehow get to the hand basin. That the toilet stall actually has a hand basin in it, and there's privacy, and there's things that we're not thinking about. But this isn't a menopause thing, it's a reproductive health thing.
Yeah.
And I think making facilities appropriate for women's reproductive health needs are completely different to going on about menopause and do you need a fan?
Yes. Speaking of, there you go. That just went in the head and then went straight out of it again. So we'll come back to the other bit that I was going to ask you about. The other thing that people were saying about, we know we have a fair bit of evidence for, in the transgender community, is people used to use implants and they had quite quite high levels. So therefore we know that it's safe as well. I forgot about that. What do we know about implants, and why aren't they as popular these days as they used to be?
Well, implants, these little pellets that are put under the skin that were available. Organon, this drug company, made them for years. And when Organon was bought out, it was felt that the equipment to make them was not as reliable, so that every implant may not guarantee exactly what it was. And that they felt at that point that there was not the market to reinvest in getting new implant production material or setups. So the implants now are mostly compounded, and which makes there's one source where they're not compounded, but they don't have the stability and the reliability of non-hormonal of non-implanted products. So once you put the implant in, you don't know if it's going to last 3 months, 6 months, or 18 months. If a woman develops breast cancer and you've got an implant in, they're little pellets. They're terribly hard to get out. And once a woman's had several implants, you've got fragments still left, so they can still be releasing hormone after you've had several for several years. You can't really control the levels. You can't stop them if you need to stop them, as I said, because they're going to be lasting for years. And I have had a patient have breast cancer who I had counseled about all of this. She got breast cancer. She had an implant in, and we had to get a surgeon to cut a whole big lump of fat out to make sure we got the implants out. So they're not as easy to manage. The bleeding's often harder to control. And that their variability in the hormone levels, like you and I could have the same implant, we'd get completely different hormone profiles. So you really can't predict how they're going to work. They're much easier to use in people who have transgendered because we know they're much more tolerant of higher levels because they will metabolize it faster.
Fair enough. Over here, they're asking about to have a GP consultation when you're in your 40s to talk about menopause, so you've got an idea of what's coming and what you can do, lifestyle things and everything that might be able to help you as you go through the transition. In your submission, you're talking about a different type of consultation at around about 50 to look at the health factors that change, the changes in cholesterol, blood pressure, blood sugar, those sorts of metabolic kind of issues as well. Why is that so important? Because I don't think that people actually really understand that it's not just mood and night sweats, but there are actual physiological changes that are going on in our body that put us at increased risk later on for different types of conditions. What are you wanting in that, and do you think you're likely to get that?
So there are two sides to this story. 70% of women don't have severe symptoms. So if they don't have severe symptoms of menopause, it's highly likely they will not discuss menopause with their doctor, because why go along to have a consultation if you've not got a problem? But just because you don't have symptoms doesn't mean that your cholesterol hasn't changed, or your bones density isn't going down, or that your blood pressure is not going up. So if all we talk about is symptoms, we're not going to identify the factors that are changing that puts women at risk of osteoporosis or cardiovascular disease. Now, that doesn't mean that you need to put everybody on estrogen to prevent those outcomes, because in fact, the Women's Health Initiative study showed that if you give estrogen, you don't necessarily change cardiovascular disease, but it does mean that women might have their blood pressure changing or the cholesterol changing, and they're not getting an antihypertensive, or they're not being counseled about their diet. So silent changes occur in women who don't have symptoms. That's the first thing. The second thing is that in Australia, we currently have a funded midlife health evaluation, a long consultation. If you're 45 to 49, you can rock up and get this long consultation. And our argument is, well, it shouldn't be based on your age. It should be based on your biology. So if a woman goes through menopause at 42, she hasn't had her consultation, but she may have needed it. If a woman goes through menopause at 53, and when she's been 47, had this long consultation and told your blood pressure's fine, your cholesterol's fine, your bone density good, nothing to worry about. At 52 or 53, she's going to think, well, I'm fine. All's good. But in fact, she needs the consultation then that fits with when things might be changing. So whereas things in the consultation 45 to 49 might be totally fine for a man, because really probably not much will change unless they put on weight or lose weight or get under stress. But for a woman, it should be linked to their biological age, and the big biological change at this time is menopause, and that's how we should be doing it. That's my belief.
Yeah, that makes perfect sense. The other thing over here, they did a reproductive health study. This was the thought that went out of my mind that has now come back. Looking at women aged between 16 and 55, and looking at various sort of symptoms and things that they may well have. Have we sold women short who are over the age of 55? We seem to have this sort of belief that symptoms will fade away, but when we're talking about the symptoms, we're normally talking about vasomotor symptoms, but it seems that, bladder symptoms, vaginal symptoms, mood symptoms, they seem to persist. Do we need more study then that goes on to look at what women who are over the age of 55 are going through?
Oh, we've documented that for women up to the age of 79.
Well, that's very nice, but what did you find?
6% of women aged 60 to 65 are still having hot flushes, night sweats. Not 6%, 42% of women still having hot flushes, night sweats, age 60 to 65, and there's severe symptoms in 6% of women. If I remember correctly, about 15% of women aged 65 to 79 are still having hot flushes and night sweats, but they're only severe in like 3%. So the symptoms do change, diminish. And we have been looking at what is really the evidence that you cannot start hormone replacement therapy after the age of 60. So at the moment, the mantra is you can't start it after the age of 60 or beyond 10 years from menopause. And we have been looking at that very carefully, and we'll be sharing information about that imminently.
Brilliant. How imminent is imminent?
Very imminent.
Excellent. Brilliant. Professor Susan Davis, I think that I've covered everything I wanted to cover. Is there anything else that you particularly want to get across?
Oh, look, I think the most important thing is for women to seek out really credible information. I know that if you're suffering and life is really difficult, it's very easy to just grab at something that's going to fix you. But there's a lot of valid information. The British Menopause Society has really good data or good information sheets and good information for women. The International Menopause Society has great information. The Australasian Menopause Society has great information sheets that anyone can download. And I think go to the places that have no agenda and no benefit from the information they're going to give you. No one's going to make any money by telling you how it is. And read that stuff before you start taking things or start doing things to alleviate your symptoms, so that you're really informed and you know the questions to ask.
Yeah, it's a very difficult thing, and it's especially in this time of the social media growth and very, very convincing speakers on both sides of the pond, this side of the world, to know what is or what isn't credible, because a lot of what they say makes a lot of sense.
Great. I could convince a whole room of people that testosterone is the elixir of youth for women if I cherry pick the data. I could be extremely convincing. I've argued that in debates, but it doesn't mean it is.
Yeah.
And you've got to go to the resources that are really evidence-based, where the people sharing those resources have no agenda other than to disseminate the real information and provide the facts.
Yeah. An interesting debate, and this is one that's going to go on for a very, very long period of time. Thank you so very much for joining us, and hopefully we will speak again soon. And I look forward to your imminent data.
Okay, all the best.
Thank you.